the outline of my talk will include going over the history, a pulmonary-focused physical exam, and then by age group, I'll be discussing differential diagnosis, diagnostic workup, and treatment considerations. So the first question is, what is a wheeze? So if you look up in the dictionary, it defines a wheeze as a verb, which means to breathe with difficulty, usually with a whistling sound. And synonyms include blow, heave, hyperventilate, pant, puff, or gasp. But what does a wheeze mean to a physician? So according to Zitelli's Atlas of Pediatric Physical Diagnosis, a wheeze is a musical or whistling oscillatory sound heard more on expiration than inspiration. So there's definitely a disconnect in what the public considers a wheeze and then what we as physicians consider a wheeze. And interestingly, there was a group that looked into this and sent questionnaires to the patients who came into the practice for wheeze and asked what they meant when they asked when they said that their child has a wheeze. And a third of them described the wheeze as being a noise when they were breathing. A third of the parents described the wheeze as being the child was working hard to breathe, and then a third described a combination of both. And then when you ask the physicians what they, if they perceived these children as having a wheeze, about 50% of them agreed with the parents and 50% felt that this was something other than wheezing. So there's definitely disconnect, and that's important to know when you get a parent who's coming in with wheezing and shortness of breath. So that guides the history. So first is asking the family, either the patient or the parents, to describe exactly what they mean when they say that their patient, that the child has some wheezing and shortness of breath. Are the symptoms acute or chronic? How long have they been going on for? And when did they start? Was it an exact precipitating event, like a respiratory illness that's now been lingering? Or has this been more insidious? And what's the progression of the symptoms? Do things seem to be getting better? For example, pertussis can have a 100-day cough and slowly things get better, or is this something that's been going on or perhaps even getting worse? And then what are the specific triggers? Does the wheezing and shortness of breath come on with exercise? Does there seem to be more noisiness with feeding, if it's an infant in particular? Are upper respiratory tract infections the main trigger? And are any of these symptoms noticeable to the parent when the child is sleeping? And then what provides relief? Cough medicines, although cough medicines aren't generally recommended in younger children, parents often will try them, so it's important to ask. Antibiotics, and if so, which antibiotics seem to be best? Nebulizers, or is it just when the patient rests from whatever activity they've been doing? And then what else has the patient tried and perhaps not seen as much of an effect from? And then what are the associated symptoms? Do they have chest pain, cough, congestion? And then also it's important to review any potential comorbidities. Does the patient have allergies or eczema? Does the patient seem to have some symptoms of reflux, treated or not? Is the patient overweight or underweight? Or do they have other symptoms like other infections, recurrent pneumonia, recurrent ear infections, things like that? It's also important to ask what the family history is like. Is there asthma in the family? Because we know that asthma, for example, is a very it's a complex genetic trait. But if there seems to be a family history, in particular if the mothers have asthma, there's an increased risk of the child developing asthma. Was the patient born in the U.S. or were they born elsewhere, or was the family elsewhere? There are not only for travel history, but also epidemiologic factors that could go into diagnosis. And where does the family live? Do they live on a farm with lots of animals around, or do they live in a city? These can have important, they can affect what the patient may be at risk for. and then what's at home. And this is mostly asking allergic exposures. For example, cockroaches, mice, mold, dust mites. And the way of asking dust mite exposure would be to ask if the patient has a lot of stuffed animals in the bed, or if there's lots of carpet, particularly in the bedroom, or if there are heavy curtains around the bed. And we ask mostly around the bed because that's where you spend, if you think about it, most of your time at home is sleeping. And so it's important to get an idea of what the bedroom environment looks like. Are there pets at home, cats, dogs, which would point more towards typical allergies, or perhaps birds, which are important to specifically ask. When you ask parents, families if they have pets, cats and dogs are what they readily offer up, but birds they might forget about. So it's important to ask if there's any bird exposure at home or at school or at grandparents' house. Is there smoke exposure? So those are the main components of the exam, which are important to discuss. Now I'll talk about the main components of the history, and now I'm going to move on to the exam. As with any organ system, there are 4 main components of the exam. There's observation, palpation, percussion, and auscultation. And often when we do a pulmonary exam, we jump right to the auscultation, and although that is a very important part, there's lots of information that we can get from the other components of the exam. So I'm going to go through each part individually. So observation, you can get quite a bit of information from this part of the exam before you even touch the patient. So what is their overall mental status or activity level, which gives you an idea of how hard they're working and for how long, if they're starting to tire from their work of breathing. Respiratory rate is important to note, and as we all know, this can range with age. So in a baby less than 2 months of age, less than 60 is normal, and it's important to catch it over a long enough time period. So usually a minute is best, because there can be some fluctuation, times where they're breathing more quickly and then more slowly. So an average over a minute seems reasonable. A baby from 2 months to 12 months of age generally breathes up to 50 breaths per minute. And then in the child age group, they can breathe up to 40 breaths per minute. And then as you get closer to an adult age, an adolescent would be expected to breathe less than 20 breaths per minute. You can also notice respiratory effort. So is the child grunting, retracting? Is there paradoxical breathing? So when I say retractions, you should look for supraclavicular retractions or intercostal retractions. You could also look for nasal flaring, and then paradoxical breathing. So is there, when they're breathing in, are they actually using their abdomen to pull down on their diaphragm so that they, and the chest wall actually is weakening, so the chest wall will pull in a little bit as their belly their belly pulls out. And then respiratory alternans is generally a sign of heading towards respiratory failure, when their diaphragmatic breathing alters with their intercostals to inflate the lungs. It's important to note skin color, if there's any cyanosis. And in general, though, you don't develop cyanosis until you have a certain percentage drop in your hemoglobin. So someone who is anemic would be slower to show signs of cyanosis than somebody who has a normal hematocrit. It's also important to look to appreciate the shape of the chest wall, and I have some pictures that I'll show you to describe both Pectus Excavatum or carinatum, and then clubbing, and I have a picture to go over that as well. So on the left is Pectus Excavatum, and you can see that's an inward shape to the chest, and you can see here in the center of the chest there's this inward concavity, and that can not only have effects on lung function but also can affect cardiac function. And on the right is Pectus Carinatum, which was more of a bird beaking of the chest wall. And here are some images of clubbing. So generally with clubbing, in severe clubbing, you can really notice this roundness to the fingertips. But I think the best way to describe clubbing is to look horizontally at the finger, and this article describes a nice way to assess for clubbing, where you compare the interpharyngeal diameter with the distal phalangeal diameter. And normally, the intrapharyngeal diameter is larger than the distal pharyngeal diameter. But in clubbing, the reverse is true. Also, another component of observation before you even touch the patient is, what do you hear? Do you hear some of the noises that the parents are describing? First, do you hear any stridor? It can be high-pitched and inspiratory, which generally indicates more of a critical airway reduction. That noise can be expiratory, which indicates more of a tracheal or bronchial obstruction. And this is actually something that we hear very commonly in practice. And this is generally, you'll hear it with mucus in the airways in young children who have an airway infection, but could also be from other causes. Is the stridor biphasic, which could indicate a fixed lesion, and that's generally at the level of the cricoid. You can also appreciate stertor, which is more of a nasal quality of their breathing. And you would observe if the patient's mouth breathing, because they're just so obstructed in the nasal cavity. And then also on observation, you could look for signs of allergy, such as conjunctival erythema, Denny lines, or allergic shiners, and I have a picture to show those, or signs of eczema. So here's a picture of an allergic-looking child. So she has these allergic shiners, and the Denny lines, which are these sort of double lines underneath the eye, sort of thickening and lichenification of the skin from just chronic rubbing of the eyes due to allergies. So moving on to the second component of the exam would be palpation. So again, before you even break out the stethoscope, you can put your hands on the patient's chest in a non-threatening manner, and you can appreciate a symmetry of the chest movements. And this also will allow you to pick up on more subtle signs of increased work of breathing. So you could actually feel any subcostal retractions or paradoxical or belly breathing. It's important also to try to feel the trachea. And normally in a trachea, it's just slightly shifted to the right. But if you would feel any deviation of the trachea, that's important to note. You can feel vibrations or rattle in the chest, which can indicate generally some form of obstruction, usually mucus in the airways. And then with an older child who could follow instructions, you could ask them to do tactile or vocal fremitus. And that's when you ask a patient to say the word 99. You can use any word, but 99 is classically used. And with your hands on the chest, you would move your hands down from the top of the chest down towards the lower rib cage, and you would feel the vibration that's created when the patient says 99. And generally, if there's an area where the vibration suddenly drops off and becomes much softer, then that would indicate air or fluid in the pleural space, or it could indicate a large airway collapse. The third component of the exam would be percussion. So we do this in other organ systems, but it's also important in the lungs. The lungs are generally more resonant than other areas of the body, And so the way you percuss, if you recall, is you put your hand on the patient, and then with your other hand you tap your fingers, and you would note if an area is hyperresonant or dull or resonant, and this allows you to appreciate the air quality in the lungs. So if you were one of the benefits of percussion is it can tell you if the patient is hyperinflated. Normally, if you were to percuss down the back of the patient, you would get a sense of the lung volume, and a normal lung volume goes just below the diaphragm. I'm sorry, the diaphragm is just below the scapula at rest. But in a hyperinflated patient, the diaphragm would be lower. So for example, in a cystic fibrosis patient, the diaphragm would be much lower on the back, so you would be able to percuss and feel that resonance much lower down on the patient's back. Alternatively, on a baby with chronic lung disease, you can percuss anteriorly, and you can feel some air trapping above the sternum. Percussion also allows you to feel to appreciate diaphragmatic symmetry. So if you percuss down on one side and you find the diaphragm is significantly lower than the other side, there may be diaphragmatic abnormalities such as eventration or diaphragmatic hernia. And now the fourth component of the exam would be auscultation. And this is what we classically think of as being the important component of the pulmonary exam, and you certainly can get a lot of information from this. But although I don't think that in general physicians are great at describing what they hear, so there's more than just listening and hearing coarse breath sounds, and sometimes it can be hard to hear breath sounds in a child who can't take deep breaths or can't cooperate and hold their breath for you or take deep breaths when you ask them to. So you definitely have to be patient. And one tip that you can use also is if your hands are on the baby's chest, you can sort of augment breath sounds by gently giving them a thoracic squeeze at the end of each breath to help so you can hear the airflow a little bit better. So when you're listening, you should describe if the intensity of the lung sounds, if they're decreased in any certain area, or if there's any asymmetry. And then the describing the adventitious sounds is important, and there are lots of ways that people describe adventitious sounds, but generally it's felt that it's best to use this terminology just to make it more comparable between physicians. And there are groups that have come up with the best terminology to use and what exactly it means. So one of the adventitious sounds would be crackles, and this is generally due to air abnormalities in the air fluid interface. And these are, by definition, discontinuous noises. You can describe them as inspiratory or expiratory. They can be fine, dry crackles or coarse, wet-sounding crackles. Another adventitious sound would be wheezes. And wheezes are generally due to narrowing of the lower airways. Wheezes, by definition, are more continuous. And when you describe them, they can be either monophonic or homophonous, which generally indicates a more central component, or they can be polyphonic or heterophonous, and those are more of a peripheral airway involvement. They can be inspiratory or expiratory or biphasic, and they are generally, by definition, more high-pitched. Alternatively, rhonchi are another adventitious sound, and these are also continuous noise, although these are generally due to narrowing of the larger airways and are generally more harsh sounding, low pitched, and more of that central wheeze, more monophonic. There are also fun components of the exam that you can do to really define what you're hearing. So there's egophony, which is something we've all learned about in medical school, but can be confusing. So there are different types of egophony. There's bronchophony, where you ask the patient to talk in a normal voice, or there's pectoriloquy, where you ask the patient to talk in a whisper. And you can use any word, although generally 99 is something that's used. And you ask the patient to say 99 or whisper 99, and you'll auscultate different areas of the lung. And if you hear the auscultated 99 louder in a specific area, that signifies consolidation. And generally, this is when people sometimes will use the terms bronchial breath sounds over an area of consolidation. What they're really meaning is that there's positive egophony over a specific area. Another fun physical diagnostic trick is having the patient say E, and as you listen to different areas of the lungs, the noise quality will change, and as you're auscultating, you'll hear an A. So that's an E to A change, and that is indicative of an area of consolidation or fibrosis. And then other sounds that you could hear would be pleural rubs, which would be creaking sounds between the rubbing of the visceral and the pleural surface. So now I'm going to go through the differential diagnosis, workup, and treatment of wheezing and shortness of breath in different age groups. And first I'm going to start with the infant wheezer. So if a parent comes in and you've gotten your history and physical, what are you thinking about in the infant wheezer? So cardiac disease, which isn't something that's top of the list most as far as incident and what's most likely, but is important to think about. So cardiac disease can cause wheezing by bronchial compression of the airways by vessels, or a vascular ring could cause compression of the trachea, and both of those could cause wheezing. Infectious causes could cause wheezing, and these are very common in infants. Just a regular URI, bronchitis, bronchiolitis, and pneumonia. They all give slightly different physical exams and slightly different histories, but often parents will say that there's some noisiness with all of these, and sometimes some increased work of breathing. And then any abnormalities in the airway. So these are sort of going from anatomically from top to bottom of the airway. Could the patient have laryngomalacia or floppiness of the airway? And I'll talk about this a little bit more in detail since this is so common. Other laryngeal abnormalities. Could the patient have vocal cord paralysis? Below the vocal cords, could there be any stenosis, some subglottic stenosis or hemangioma? Or is there tracheomalacia? And again, I'm going to talk more about tracheomalacia because it's very common in this age group as well. Reactive airways or asthma is also very common, and I'll briefly touch on this, but I know there's another chapter on reactive airways and asthma, so I'm not going to go too much into detail on that. Congenital lobar emphysema is rare, but something to consider. And then another rare entity, but you have to think about these more rare diseases so you don't miss them, would be congenital cystic adenomatous malformation, or another congenital pulmonary airway malformation. So as I was mentioning as I went through the list, the common causes of wheezes include infection, reactive airways, laryngomalacia, and tracheomalacia, plus or minus reflux, which I'll touch on in a bit. So here are some images of laryngomalacia. So laryngomalacia is very common in infants. It's this omega-shaped epiglottis and with extra floppy folds over the arytenoids. And so as you can see, this is expiration. When the patient breathes in, the floppy tissue and the epiglottis fold onto itself and cause considerable narrowing of the airway. So you can see there's just this tiny little hole where the air can get through. So the quality of the sound changes. as the air flows through that small hole. And the noises are high-pitched and inspiratory, and the baby often will have some retractions as well, depending on the degree of laryngomalacia. And generally, though, and this is important to ask the family, but generally there are no symptoms at birth, and that's because the baby's work of breathing isn't strong enough to create enough change in pressure with each breath to pull the tissue in to cause that blockage. But this will develop as the baby grows and becomes a little stronger and the lung volumes grow. These noises will become more evident. So generally, after the first few weeks of birth, this stridor can become evident. And generally, there's no treatment recommendation. It's just reassurance and supportive care. But this resolves over time, and often the treatments can cause more long-term issues. If it's very severe, tracheostomy can be performed as the patient outgrows the laryngomalacia. But generally, it's reassurance. So moving on to tracheomalacia. So this is a picture of tracheomalacia. And the quality of the pictures for tracheomalacia are never as good as as many of the airway pictures that you see, and that's because of the technique that is needed to capture tracheomalacia. So generally, the best way to diagnose tracheomalacia is by flexible bronchoscopy, where a small bronchoscope is put into the airway, and without obstructing the airway or causing any extra pressure in the airway, you just observe the patient while they're breathing. And just because of the quality of the bronchoscope, the flexible bronchoscope, the images of the quality are not as pristine. But the essence is still there. So on inspiration, you see a wider airway, still a little bit of floppiness. This is the membranous part of the airway, the muscular part of the airway, and then the C-ringed cartilage comes up over here. And you can tell already it's a little bit narrow. But when they take a deep breath in, when they take a breath out and they don't have that pressure holding the airways open, there's some compression of the airway. So what are the causes of tracheomalacia? Most commonly, it's a normal infant, and it just has to do with the development of the cartilage, which can take some time. So all babies have some degree of tracheomalacia. There can be syndromes associated with tracheomalacia. Down syndrome, for example, can have tracheomalacia. DiGeorge syndrome is an example of a midline defect that can have associated tracheomalacia. Connective tissue disorders, such as Marfan's or Ehlers-Danlos, frequently have a component of tracheomalacia. And then there are these very rare pulmonary specific causes of tracheomalacia and abnormalities in the trachea. Meunier-Kuhn, which is an abnormality of the smooth muscle within the airways in the trachea, and then Williams-Campbell, which is an abnormality in the cartilage within the trachea. And then there are secondary causes of tracheomalacia. So whenever you do think about tracheomalacia, you want to make sure you're not missing a secondary cause. TEF, or tracheoesophageal fistula, can have tracheomalacia, and that has to do with the development of the trachea and the esophagus. If there's vascular compression, can cause narrowing of the airway. Other masses, whether it's lymph nodes or tumor, congenital cysts, can cause narrowing of the airway. And then chronic inflammation can also cause narrowing of the airways. So chronic aspiration or chronic reflux or chronic untreated asthma can result in inflammation of this airway and cause some degree of tracheomalacia. Now, it's important to note also that if you treat some of these secondary causes, for example, if there's vascular compression and you lift that vessel off of the trachea, or if there's a congenital cyst that's been pushing on that trachea ever since the baby was in utero, there's probably going to be some residual tracheomalacia just because of the abnormal development of the trachea. And then I alluded to tracheomalacia or Laryngomalacia and reflux. So there was a study that was done that looked at over 100 infants, half of which had malacia and half of which were controls. And all of these children had a flexible bronchoscopy, plus some of them had other studies as well, like a chest x-ray, barium study, or pH probe. And they asked the question, which of these babies have reflux? So generally, half of the babies with tracheomalacia alone had reflux. A little bit more of the babies, about 63%, that had laryngomalacia also had reflux. And if the baby both had laryngomalacia and tracheomalacia, there was a high likelihood that this baby also had reflux. As compared to a little less than half of the babies, 39%, who did not have any malacia had reflux. So generally, the feeling is if there's floppiness in the airway, there's probably also some floppiness to the gastroesophageal sphincter. So the baby may be at more risk for reflux. And as I mentioned in the last slide, reflux can exacerbate the tracheomalacia. So if you have a high suspicion for malacia and a history consistent with reflux, it's reasonable to treat the reflux as well. So further workup, now that we've gone through the differentials, the workup for infant with wheeze, generally the history will guide the diagnosis, and you don't need to do much more of a workup. The exam can be tricky because it can be similar between all of these different diagnoses. However, if the symptoms are atypical or seem to persist, it's reasonable to get a chest X-ray. And so what not to miss? What would the things be that you'd be worried about in this patient population? So first would be cardiac disease, and that can simply be ruled out with a chest X-ray, or if there's any abnormal findings on the cardiac exam, you'd want to pursue more of a cardiac workup. But if you're worried about a vascular ring causing this noisy breathing, then you could do a chest X-ray, and I have a chest X-ray example to show you. You could also do. You could also be worried about cystic lung disease. So in general, cystic lung disease should have some asymmetry in the auscultatory component of the exam, and likely actually the other components of the exam. So you would hear focal decreased breath sounds. Also, with cystic lung disease, they would unlikely be responsive to any nebulizer treatments that you would try, like albuterol. So a chest X-ray would be reasonable to do in this case as well, and would show you any cystic lung disease. Upper airway abnormalities can also be important to not miss, and so the quality of the wheeze would be a little more characteristic of an upper airway noise, or more of a homophonous wheeze, and that would not get better with treatments. So if there's a severe upper respiratory findings that don't respond to typical treatments, or if the symptoms seem to be getting progressively worse, this is a patient group that I would recommend you do a bronchoscopy on with your ENT colleagues. And then any other signs of lung disease, if there's crackles, if there's recurrent pneumonia, then I would consider broadening the workup. So here's a chest X-ray of a patient with a vascular ring, and you can see the trachea. As I mentioned, it should normally it goes slightly to the right of the patient. So this is the patient's right over here. So normally the trachea should deviate slightly to the right, but in this case it's being pulled to the left, and that's because of a vascular ring, and that's classic for a vascular ring. And then also a congenital pulmonary airway malformation you can see this cystic area in the lung. And here are some pictures of some laryngeal abnormalities. So laryngocele, a supraglottic hemangioma, a congenital cyst of the newborn, or a papilloma. So these all would generally present with noisy breathing and wheeze and some increased work of breathing, but there would be some subtle differences in the history or the timing of the events. For example, this congenital cyst this baby would be noisy and wheezing at birth, and this, would be evident and abnormal from the very beginning. So what's the treatment in an infant wheezer? So 1/3 of all children have a wheeze by 3 years of age. So it's absolutely reasonable to trial albuterol and perhaps inhaled or oral steroids based on the history as well, and see if that makes a difference in the baby who wheezes. That's not to say that these children all go on to have asthma, but they have some episodes of wheezing, and some of whom do go on to have asthma, some of whom outgrow their asthma. If there's a chronic wet cough that the parents are describing as this wheeze and shortness of breath, there have been studies that have looked at the actual airway and done bronchoscopy and also washings of the mucus in the lungs, and they've found that patients who have a chronic wet cough lasting more than a month, almost half of them had a bacterial component. So if the cough, when you hear it, if the wheeze and the noisiness is wet in quality and it's been going on for long enough, it's reasonable to try a course of antibiotics, and the antibiotics that would treat the normal airway bacteria like strep, pneumo, Haemophilus influenza, Moraxella, Catarrhalis. And also in these patients with this chronic wet cough, they found that a fair amount of them had some degree of malacia. And generally, malacia does improve over time, so you can reassure the patients, and probably treating any underlying reactive airways or infection or reflux can also help treat the malacia. But then there's a possible treatment of hypertropium that's helped, and there was a group that I work with who looked at the effect of hypertropium on malacia, and this was a small series, but they found that a little over half of the patients did improve on hypertropium nebulizers. So in summary, for an infant wheezer, likely causes would be a viral URI, although this could be concurrent with another diagnosis, such as laryngotracheomalacia, plus or minus reflux, and then if there's a bacterial component, there could be a bacterial component if it's a chronic wet cough, and also reactive airways. The workup, a possible chest x-ray, but not needed. And then treatment options would be albuterol, ipratropium, or antibiotics. So to move on to the next age group, we're going to discuss the child wheezer. So the differential for a child wheezer is very different than the infant wheezer. And top of the list is asthma. And by far, it's the most common cause of wheezing and shortness of breath in this age group. You can think about the other causes of wheezing and shortness of breath by areas of obstruction in the airway. So is there an intrinsic obstruction of the airway, such as subglottic stenosis or vocal cord paralysis? Vocal cord paralysis could be due to like a Chiari malformation or prior surgery if they've had any surgery. Or could there be a foreign body in the airway or in the esophagus that's compressing the airway? And any extrinsic compression of the airways, like a mass or lymph node. Congenital pulmonary airway malformations could cause extrinsic compression of the airways, like a bronchogenic cyst or a CCAM or sequestration. Inflammation of the airways also cause wheezing. So aside from asthma, could there be an infection, pertussis, chronic bronchitis, hypersensitivity pneumonitis, which I'll talk a little bit about later, cystic fibrosis, or primary ciliary dyskinesia, which is a mutation in the cilia within the airway, which can cause chronic airway infections and bronchiectasis. So what would the workup be for a child with wheezing? Like I said, asthma is far and away the most common cause of wheezing and shortness of breath in this age group. And there's a whole nother talk on asthma, so I won't go too deep into this, but generally history of a cough, wheezing, shortness of breath is really classic, and you can base much of your diagnosis on the history. You could try albuterol and see if they respond to albuterol, and if they do respond, that's highly suggestive of asthma. If you catch them during an exacerbation, you would hear polyphonic wheezes and heterophonous wheezes. A child, if they're old enough, could perform spirometry, which is a test when they breathe into a tube that's measured, and it measures flow and volume changes. And then other things that you could do to support a diagnosis of asthma would be to measure an IgE, and that not only supports a diagnosis of asthma, it also can go on to predict whether or not this is an asthma that will resolve, or if this is asthma that they'll contend with over the years to come. A CBC is also helpful to show eosinophilia in asthma, and then also looking for comorbid allergies. So allergy testing not only would support a diagnosis of asthma because allergies and asthma go hand in hand, but also could identify potential triggers that they could avoid in the future. If there's any atypical history or any atypical findings on the exam that would not suggest asthma, like crackles or other findings, then a chest X-ray would be indicated. Depending on the history in the exam, hypersensitivity panel could be indicated to look for hypersensitivity pneumonitis, which is an IgG related allergy. And then also, if you were worried about cystic fibrosis or primary ciliary dyskinesia, you could do a sweat test or a nasal biopsy, respectively. So what not to miss in this age group? Foreign body. Children are very active and can often eat and run and talk. They're busy, so it's usually there's an event that makes a parent concerned for aspirated foreign body. And when you listen to them, you would typically hear asymmetric breath sounds, or you'd notice asymmetric diaphragmatic excursion or a unilateral wheeze, but these findings aren't always there. You could do a chest X-ray, and again, if the suspicion is high enough, you should still go to a bronchoscopy, even if the exam and the chest X-ray are normal. And I have an example to show you that soon. Bronchiectasis is also something not to miss because that generally indicates a different disease process that should be addressed to prevent progression of the bronchiectasis. So bronchiectasis would generally have focal, high-pitched inspiratory wheezing, or a homophonous, low-pitched rhonchi that doesn't clear with albuterol. And if you have findings that suggest bronchiectasis, a chest X-ray is a reasonable first step, but a chest CT might be indicated as well. So here's a picture of a foreign body. So you can see atelectasis of this left lower lobe and indicating airway obstruction. And then when we went in with the bronchoscopy, we found what was likely a piece of popcorn stuck on one of the airways that was that we were able to successfully remove, and the patient got better. And here's an image of bronchiectasis. So this patient had recurrent wheezing and was treated as asthma for a while, but began to develop crackles. And when we did a chest X-ray, seemed to have an area of consolidation, so we then moved to the chest CT, which shows this area of bronchiectasis in the right middle lobe. So what's the treatment for a child with wheezing? So as I mentioned, asthma, so albuterol plus or minus inhaled or oral steroids are really the first line of treatment. If there's a concern for an intrinsic or extrinsic airway obstruction, then removing the underlying obstruction. And if there's inflammation of the airways, then possible antibiotics could help. If you diagnose hypersensitivity pneumonitis, then the treatment would be simply to avoid the trigger. Or if the patient has cystic fibrosis or primary ciliary dyskinesia, chronic therapies, which are beyond the scope of this chapter, would be helpful. So in summary, the likely causes of asthma, of wheezing and shortness of breath in a child are asthma and plus or minus a viral trigger. And workup is not needed, but if it is pursued, spirometry, IgE, a CBC with diff, and allergy testing would support the diagnosis of asthma or point you in another direction. And a chest X-ray could be helpful. And then the treatment options would be albuterol or disease-specific treatments if indicated. So moving on to the teenage wheezer. So the differential in the teenage wheezer is very similar to that in a child who wheezes, but there are a few subtle differences. So vocal cord dysfunction is much more common in an adolescent than it is in a child, although it certainly can occur in a child. Asthma is still very common, although if a patient is wheezing for the first time as a teenager and never had any history of wheezing, I do actively try to convince myself of that diagnosis and make sure I'm not missing something. Pertussis, or another airway infection like enterovirus, can cause transient wheezing or prolonged symptoms in somebody who hasn't wheezed before. Mass, either a tumor or lymph node compression or granulation tissue, can cause airway obstruction and cause wheezing and shortness of breath. Angioedema can cause transient airway shortness of breath and wheezing. Irritant inhalation can cause these symptoms. Smoking, e-cigarettes, these sort of things are important to ask about, perhaps with the parents out of the room. Bronchiectasis, similarly as the child who wheezes, bronchiectasis could be a possibility in the differential. And hypersensitivity pneumonitis. And hypersensitivity pneumonitis is more common in the adolescent age group than it is in the younger child age group. So what would the workup entail? So history is, again, the most important component. So vocal cord dysfunction. When you ask about vocal cord dysfunction, is the wheeze inspiratory? Do they feel a tightness mostly in the throat rather than, in the chest? Do they have any cough? Typically, asthmatics have some degree of cough, whereas if they don't cough at all, it's mainly this tightness that's probably more consistent with vocal cord dysfunction. Personality-wise, these are generally people who are very competitive and really pushing themselves. Either they're competitive athletes or overachievers in other ways. And again, these patients would not have a history of asthma or any allergy or atopy. In asthma, on the other hand, they would have wheezing, cough, shortness of breath. There'd be specific triggers, like when they have a respiratory infection. And if you treated them with albuterol, there would be a clear response. On the exam, if you hear a polyphonic wheeze, then that would be very classic for asthma, and you'd feel very comfortable in the diagnosis of asthma. If there was more of a homophonous wheeze or crackles or rhonchi, then I would worry that maybe we're missing something else, so I would want to do a chest x-ray and a possible CT. And as I mentioned, spirometry, and I have a picture coming up of what a spirometry readout looks like, but spirometry or IgE or RAST, which is a type of allergy testing, or CBC with DIFT would support atopic asthma. However, not all asthma is atopic. So even if a patient doesn't have a high IgE, has normal count of eosinophils, and doesn't have any allergies, they still could have asthma. So it's not required, but it can be helpful. So if there's anything atypical in the exam or the history, then I would pursue a chest x-ray, likely a hypersensitivity panel, and probably a sweat test or nasal ciliary biopsy, depending on my clinical suspicions. So what do you not want to miss in this age group? A fixed airway obstruction. So if there's a homophonous wheeze or very focal wheeze, you should do a spirometry, which is helpful in this age group. They would be able to do high-quality spirometry. And that is helpful in differentiating upper airway obstruction versus lower airway obstruction. A chest x-ray can be helpful, and bronchoscopy can be helpful. Hypersensitivity pneumonitis is also important not to miss. And as I mentioned earlier, this is an IgG-mediated allergy. Typically, these patients have crackles and rhonchi. So on exam, it's important to ask about bird or mold exposures. The mold exposure may not always be evident. And if I had a concern for this, it's a simple blood test looking at the hypersensitivity panel. And then any other findings that are worrisome, like crackles or rhonchi, asymmetric breath sounds, then I would pursue a chest x-ray and possibly a chest CT. And then there are other things that happen in teenagers that can cause abnormal exams, and generally these are infectious, so virus or enterovirus, atypical pneumonia. So these are just things that can cause abnormal exams, and as with the case of atypical pneumonia, maybe a Z-Pak, but otherwise these will resolve over time, and so it's important not to jump too quickly to a workup unless you're really worried. So here's an example of a flow volume loop produced by spirometry. So and on the left is normal. So the patient breathes into this machine, and they breathe hard and fast, and you can measure the flow of the air over time. And this is perfectly normal. So you have a rapid airflow, and then it sort of tapers off over time in a very predictable manner. And then this is the inspiratory loop when they're breathing back in. So in this patient, this is abnormal, and there's a rapid initial outflow of breath, but then it's flattened and plateaued, and then the patient breathes in again. And this is very abnormal. So you can really appreciate the differences between the two. In a case of a fixed airway obstruction, here's an example of a patient who was in a car accident several months ago and then developed asthma over the next few weeks and was treated with albuterol and just not really getting better. And so they did a bronchoscopy because his findings were so unusual. And you can see here are the vocal cords, and just distal to the vocal cords, this is what you see, this significant airway obstruction. Probably had some trauma to the airway in the car accident that wasn't fully appreciated and had this stenotic reaction. You can see some narrowing of the airway on chest CT as well. And that was treated, and his airway was, and they opened up the lumen. Another example would be a mass, such as a pseudotumor. And here, again, this patient developed asthma, never had asthma before, and on chest x-ray had some abnormal findings, which led to the chest CT, and you can see this mass in the airways with a little bit of a post-obstructive pneumonia and atelectatic component. And here are some images of hypersensitivity pneumonitis. So this is a patient who had wheezing and had to come into the hospital. A classic story is they come into the hospital and they respond very quickly, and they're much better, and they go home and their symptoms slowly progress over time. And because this had been so chronic, a chest x-ray was done which showed these diffuse nodules, and then a chest CT, which is quite dramatic with these nodules and opacities. And so this patient had a hypersensitivity panel sent and came back positive for molds, and looking at then doing a home inspection is really important. So what's the treatment for a patient, adolescent with wheeze? So if you suspect vocal cord dysfunction, it's reassurance, and it's important not to over-treat these patients. And if they're using albuterol and using it a lot and it's not really helping, then I would recommend that they stop the albuterol. And behavior modification plays an important role, and which is a little beyond the scope of this talk, and I have one reference, but there are several studies that have proposed different treatment techniques. And so generally a speech pathologist would be helpful to have involved in this patient's care. Asthma is also, if you suspect asthma, then giving albuterol plus or minus inhaled steroids. And in this group, particularly in the teenagers, making sure they're doing their asthma treatments correctly and regularly is important. If there's a mass of any sort, then removing the mass obviously would be an important treatment. And if there's anything like hypersensitivity pneumonitis, angioedema, or irritant inhalation, then avoiding the triggers is important. And as with the children with bronchiectasis, determining the cause of the bronchiectasis and then tailoring therapies is critical. So in summary, for the teenage wheezer, the likely causes would be vocal cord dysfunction, asthma, or viral trigger. And the workup Again, history and physical exam can guide your diagnosis and treatment, but a spirometry or IgE, CBC, and allergy testing could be supportive, as could a chest x-ray if you're concerned. And then treatment options are albuterol or specific treatments if indicated. So the overall summary to compare the different age groups. In the infant, infection, asthma, and malacia, either Laryngomalacia or Tracheomalacia, plus or minus reflux, are very common. And then in that child, asthma or an airway infection, and in teenager, vocal cord dysfunction, asthma, or airway infection. And I do want to point out that infection can occur in concomitantly with any of the other underlying causes, and often is the trigger to push them over the edge and make their symptoms more evident and lead them to more of a workup. So what is the workup? So in an infant, a possible chest x-ray, and all of these are possible because further workup isn't necessarily needed. In a child, spirometry, CBC, IgE, allergy testing, and possible chest x-ray. And this is the same workup that could be indicated in a teenager as well. And then the treatment. For all of them, albuterol is a reasonable first step. In a teenager, if you're worried about vocal cord dysfunction, behavior modification is critical. And then in an infant, there's lots of overlap. And so a trial of albuterol, a trial of Atrovent or ipratropium, and or antibiotics if indicated. And then the next steps. So in the infant, the next steps would probably be a bronchoscopy to take a look at the actual airways, particularly the upper airways. A chest CT could be helpful, or a brain MRI if you're concerned about a Chiari malformation, for example. In the child, again, the child and the teenager have similar next steps. So chest CT, bronchoscopy, pertussis titers, a sweat test, or ciliary biopsy. So the key points of this talk would be that the history is really crucial, and getting a thorough history is very important. The second would be to articulate your exam findings and have fun with the physical exam. The third would be that causes of wheezing can vary depending on the child's age and can therefore guide treatment. And then the fourth key point would be that if there's any atypical initial presentation or recurrent presentations, then you would want to consider further workup options.